plus or minus a fellowship. So without further ado, I'd like to welcome Dr. Sanders. Thank you.
Thank you so much, Dr. Brott. Pleasure to be here today. So we're going to go through U.S. Navy diving and hyperbaric medicine. A couple of things I've done in the past. I did the DMO tour, as said. I've also been a submarine medical officer, dry deck shelter officer, and a saturation diving medical officer. As we go through the talk, I'll kind of emphasize those later. I do want to say that this talk is not a talk from the U.S. Navy. It is my talk, my opinions on the U.S. Navy, and my experiences. Almost all the photographs are my private photographs and my private experiences, right? I have no other disclosures other than please don't take any of my talk and apply it to your own private diving practice. It is not medical advice. All right, so we're going to use some Navy jargon because I am a naval officer. So our float plan for this talk is going to have 3 stops. We use stops in diving to denote where we let off divers, release divers in the water column. So our first stop is going to talk about what is a DMO, what is the pipeline, what is the training, who goes through this training. Second stop are going to be the medical topics of diving medicine. And if we have time, we'll go through the third stop, which I consider more novel topics in diving medicine or contemporary topics in diving medicine. So we'll see here, I also include pictures throughout this presentation. You may or may not be familiar with this image of the diving helmet. It's actually what we call Mark V. We use it as the image or icon of Navy diving. When you see it in this pattern with 2 seahorses and a caduceus on the lapel, that represents diving medicine. Silver would represent an enlisted diving medical technician or a diving IDC, which is like our mid-levels, or a gold or bronze one would recognize or denote a physician. 20 Tech 10 is the class I went to dive school. So the year 2020, first class out of 2 per year, diving medical officer. And then unusually close is a inside joke, which I am not going to mention on recording, but if you want to know afterwards, I'm happy to elaborate. All right, so first stop. This picture shows one of our diving medical officer classes entering the pool like we'll be doing. This is what we call the aquatic training facility at our dive school. It is a 40-foot deep pool with multiple layers that also has a submarine simulator to allow us to enter and leave submarines. It is a wonderful facility. And as you can see here, they're all entering the water the same way. And throughout diving medicine, we emphasize doing everything the same way, and I'll talk about that. All right. So as an undersea medical officer, I frequently get asked, do you take care of marine mammals and seals? No, I wish we did. I do take care of marines, which probably are a little closer to the animal side than the sailors, but still very much not veterinary medicine. All right, so what is diving medicine? And what is it between a diving medical officer and an undersea medical officer? Most of us in the diving community still use the title diving medical officer, even though modern Navy nomenclature since 2019 has said we are now undersea medical officers. This differentiates us from the Air Force and Army, which have diving medical officers as well, who undergo a much shorter training period than we do. So what is different than us in the Navy? We do radiation medicine. We do submarine medicine, which our sister services don't do. We are also allowed to modulate diving treatment tables in the hyperbaric realm, which makes us undersea. However, being traditionalist, we still refer to ourselves as DMO in normal talk. So the other parts left out, SO is special operations. So all Navy SEALs, SWCC, which is Special Warfare Combatant Crewmen, Marine Corps Recon, and Marine Corps Special Operations MARSOC are all treated by diving medical officers. All right, this is a picture of me and 2 of my DMO colleagues down at Naval Diving Salvage Training Center. People rarely believe me, there are 4 of us, and I always tell them out of all 4 physicians, I was actually the smallest at 210 pounds. So here's some proof that there are some very large men in the diving community, which you'll see is actually kind of counterintuitive because we work in very small spaces. So I don't know how this large size thing came about, but it did. All right, we do have some mottos unofficially in Navy diving. The first one is always look cool. And there's another word in front of that. You can use your imagination. And when I was a dive candidate, they said this to us repeatedly. And at first I thought it meant to dress like the image on the right. But in fact, what it entails is always be professional. Diving and diving medicine is rarely casual medical issues. It is usually life-threatening situations with minimal room for mistakes, knowing your protocols, knowing your procedures, being ready, and when things happen, being smooth and calm. The other thing at our Department of Diving Medicine, our motto was Ludere Vincere, play to win. I think all too often, both in civilian and military medicine, we use the motto, it's always been this way. If it's not broken, don't fix it. Or as we used to say, playing to not lose. However, in diving medicine, it's a little different for us because all of our patients are our close friends in our unit. So under this stress, we actually worked really hard to always improve. No, we're not perfect. It's exhausting, but we tried to keep this momentum going throughout our career. Once again, easier in a small department with a small patient population, but that's how we operated. This very jovial uniform is known as the Tropical Androsky. You'll probably never see it again. It is not an official Navy uniform, but it is endemic in the diving community. All right, so what is the Navy pipeline for DMO? You have to go to medical school. You have to either be internship or residency trained. Historically, a lot of DMOs were internship trained, left GME, did a DMO tour, and then went back and finished residency. We are now, as a Navy, transitioning more to residency trained DMOs, and we are kind of in the transition period for that now. Diving medicine has 3 phases, all under the auspices of Navy Undersea Medical Institute in Groton, Connecticut. Phase 1 is roughly 9 weeks. It is a sort of assessment and selection, so you'll be selected through a match just like you would in any other fellowship. You go through rigorous physical training, mainly in the water, as well as intense studies in radiation medicine and submarine medicine. Those candidates who pass that will go on to Naval Diving Salvage Training Center, also known as NDSTC, for dive phase, which is what we all think about. That's where we learn diving medicine, hyperbarics, and we become qualified Navy divers. Phase 3, we return, we take our internal Navy oral boards, finish up all our exams, and get assignments out to the fleet, and then specialized training depending on whether we're going diving or submarines. The training usually takes about 6 months. There is some waxing and waning depending on the year. Most tours are 3 years. Second tours do exist. Most second tours are done by residency trained physicians. And those who want to make a career out of hyperbarics or diving medicine will either go on to hyperbarics, like a fellowship, which is 1 year accredited. They may do a fellowship in our residency in aerospace medicine, which is a Navy residency, or they may become submarine medical officers, or they may do all 3, which we do see. All right, so pass, you can either generally go diving or submarines. Oh, sorry, I left out a picture. This is me and my dive partner. He's operationally deployed, so you can't see his face. This is us on the deck of what's called a YDT, Yard Diving Tender. It is a specialized Navy vessel that has not only a diving or a hyperbaric chamber for treating dive injuries, but you can see on the back, those dials, basically its own anesthesia machine, so we can mix our own gases and do our own compressions and maintain any diving operations we need. It also has a kitchen and a bathroom, so it's a great vessel to be working on. All right, so what are the paths? You can go special warfare, EOD, ship husbandry, which most people don't think about this, but our ships out at sea or in port actually require a lot of working divers to repair and fix. So a large part of Navy diving is what we call ship husbandry. That training commands, like I was the United States Marine Corps, are special warfare combatant crews, or you can go the submarine route, either squadron small, group large, or radiation, which is like the engineering school. So this is a picture of my buddy and me in the South China Sea. You can see we're smiling. We had been spearfishing in the reef. We had been chased out of the water by like a 7-foot gray shark, but had managed to keep our fish. So we're very happy. We had also managed to keep our hands. So it was overall a win. He's actually back in Japan. So we'll be reunited soon and doing the same adventures. All right, how did I get there? Undergrad, grad school, med school. I did my internship. It was actually my first internship that I decided I wanted to join the Navy and be a DMO. At that time, the Navy, because I was already in internship, said you can either do family medicine or you can do internal medicine, or you can find another branch of the military. So I went family medicine, was forced, strong word, told I was going to do a Greenside tour with the Marine Corps, which was excellent. Applied to the military match for undersea medicine. I got it, went through dive school, did my dive tour at NDSDC. At that time, I was offered either to continue in the global health realm as a global health fellow for the United States Navy, or to go into anesthesia to fill a need for anesthesia residents in the operational realm. And obviously I went that route. And then my future as of now is I'll be going back to Japan this summer for 3 years, and then probably getting out of the Navy and becoming a civilian. This is a picture of me after running up Mount Fuji. It was really sunny for most of it and then really cold at the top. If you get the chance to go to Tokyo and do Mount Fuji, completely recommend it. All right, so phase 1. This is us on the grinder. You'll see everyone's the same. They intentionally give us these gear bags that are terrible to carry, and they intentionally give us clothes that are not warm enough for the environment. So the idea is in diving training to distract you and make you uncomfortable to prepare you for the real world of diving where it is uncomfortable. I think those of us in anesthesia can appreciate that it's comfortable until it's not, and diving is very similar. So here we are, we're lined up. They'll give us a series of tasks designed to make us fail, and then we will undergo education, which is just punishment. So part of our training, as I said earlier, is actually most of the time in the pool. So 2.5 hours a day, Monday, Wednesday, Friday, we would be in the pool. Once you're in the pool, you don't leave the pool, you don't touch the side of the pool. If you need to drink, you drink in the pool. If you need to eat, you don't eat. And to make it more miserable, you can see the back doors open. It's like 15 degrees in Connecticut. And we would just sit there, intentionally designed to make us miserable to keep you calm. Now, at the time, I thought it was the worst thing ever. And if you want to talk about bad Sunday scaries, think about getting up at 4 a.m. and knowing you're going to freeze. But the Navy diving training works. And when you get through all of it, if you talk to any DMO, you're like, it probably should have been harder, but I'm glad I went through it. All right, and here's another part of our dive training. This is known as a sub, I think it's a sub disaster simulator, but this actually simulates being in the engine room of a submarine. And what will happen very shortly, which I don't have a video of, unfortunately, is it will sink. So the lights go out, the panels collapse, 50-degree water fills up in some places over your head, and you learn how to fix a sinking sub. Generally for us, they designed it to fail. So you work to completion, which is losing, and you learn to work as a team. And even though you know it's a simulator, it's the only simulator I've done in the Navy that was actually like scary. So, and cold water, even when you know you're safe and you can see the out, still hits you. But once again, great training, because everything we're doing is making us uncomfortable so that when we get uncomfortable in the real world, we're used to it. All right, so here I have some videos. I hope the volume's appropriate. This first video is taken from my class video, so it's kind of just a quick survey of various things we face.
I feel unfazed, like when I'm with my friends with a cup raised. Hey, on Monday, I got a gun raised. Suicidal, do a die until hump day. Then I go right. An automatic, more drinks, more songs, more beats to rap. I need a shrink, I'm gone. More time keeps passing, no watch, no thoughts at all. Just a hat, new era. Wet my P's and those O's. Need the Phillies with the orange and black to feel home. From Citizens Bank back to Camden Yards. It's a tale of two cities, and trust we go hard. Trust we go hard, yes we go hard. You said we go hard, I said we go hard. Rocking my Bob Cousy, stocking up on the loose. If the lyrics come easy, but the life is a doozy. And yes, I'm I feel.
Oh, sorry about that. So this other video shows us like on the pool deck and what our physical training would look like. This physical training would happen twice a day, every day for about 9 weeks. So you may be asking yourself, why are you wearing those stupid shorts? Tradition. So those shorts are called UDTs from the underwater discipline teams of World War II. In the Navy, if it was done before you, it'll be done after you, and we just still wear them. They are not comfortable, especially when they are sandy. All right, here's another video. So this is more training we would do. As you can see, a lot of in-water training, a lot of breath hold, a lot of cold water training. Right. And every video I've shown you so far, those are all physicians, all undergoing medical training. Another part of phase 2 is what we call pool weeks or pool problems. We would never call it drown proofing in the Navy. And if anyone in the diving community hears me call it drown proofing, they're going to think I'm silly. But I think for the civilian or for the person not familiar with Navy diving, this is what it is. So we actually undergo a series of what we call pool weeks or pool problems, where our dive gear is removed from us, not to simulate combat, but to simulate loss of dive gear in either the break, the shore, prop wash, turbulent seas, all of which happens. And here's a clip of it. So before you think like this is hazing, this is torture, it's not hazing. It was a little torturous, but it does work. And we use the crawl, walk, run phenomenon in Navy diving medicine to prepare. And when you're undergoing this in the pool, you think this will never happen. As a guy who's been out in the ocean with the Navy, you do lose your gear and you do have to stay calm. And this training has helped me infinitely as an anesthesiologist, right? Because unlike in diving, when the patient's not breathing, it's the same thing, right? What do I do? How do I oxygenate? How do I ventilate? And it's the same mindset of staying calm and focusing on getting things running, checking your system. Almost a 1-for-1. And out of all the training I've shown you so far, while this looks the most graphic, it was actually the easiest because no one was yelling at you. You're just underwater. You just focus on breathing. And when you're getting beat, that's probably the wrong word, but when you have these problems imposed on you, all you do is count because you know it's going to stop. So you're just sitting there counting to 30 and then you just put your gear back on. And I mean, it hurts a little bit. It's not quite so simple, but that's pretty much it. Unlike when you're doing the sit-ups in the water, terrible. You can't really count your way through that. All right, phase 3, by this point, we're done. We've all had assignments. We're back in Groton, Connecticut. In this case, we're in Groton Long Point. And life's good, and we're all about to go back to the fleet. All right, what's our second stop? We're going to start talking about diving medicine. Before we do, these are 2 images from the deck of a submarine in the United States Navy. This large cylindrical structure in the right picture is what's known as a dry deck shelter. It's a specialized hyperbaric chamber, which we actually use for the mini subs for sealed, or what are also known as sealed delivery vehicle, or SDV. It's a niche world of the undersea medical community, which I was lucky to be a part of. And if I hadn't gone back to residency, this is what I would still be doing. Submarine life is great. It sounds very claustrophobic. I actually really enjoy being on submarines, even as a slightly larger sailor. It's always 67 degrees. There's plenty of time to work out. And believe it or not, the food's very good because they want to keep up morale. And all your buddies are within 250 feet and there's no commuting to work. So it's a very, very good life. All right. So I'm sorry, the slide got a little bit unformatted. So now we're kind of into the diving medicine part of the talk. So dive physiology, and all of these next couple of slides could be lectures in and of themselves. So I'm going to hit the wave tops. So dive physiology is essentially the mammalian dive reflex. So as we dive, pressure increases. I think we can all visualize that and feel that, especially in anesthesia. Your lung volumes decrease. Due to this and the hydrostatic pressure on our limbs and the cold water, we get venous constriction. So we get an increase in central circulation, increased central vascular pressures. Our stroke volumes go up. Over time, as part of the MDR, so with the mammalian dive reflex, there's some arguments. It happens immediately. You get an increase in breath hold. Some say it's only for the first dive. Others say it's for the continuation of the dive. In my experience, I find that after about 15 minutes, especially with breath hold diving or free diving, my breath hold has increased and stays increased until I fatigue out after about 2 hours. And even on compressed air, your breath hold will quickly go up to about 2 minutes of relatively little effort of holding your breath, which is like an absurd thing to feel. And when I do free diving, it actually will sometimes become so easily I have to set an alarm on my watch to remind myself to come to the surface, because you'll get into this kind of euphoric state. Another thing that happens is known as immersion diuresis. Because of all this central shunting of fluid, your body feels that it is fluid overloaded. Anyone who's been in a pool, well, assume it's none of you, have had the desire to urinate. It's because of this. Even if your head's above the water and your body's in the water, it'll cause that shunting. This can actually become a big problem for us in diving medicine for prolonged dives. The diving injuries, such as DCS especially, are more prone in dehydrated individuals. So we know our divers are severely dehydrated because they're at depth and they don't have the ability to hydrate. And this is something in diving medicine we're always worried about, is hydration status. All right, here's another video of just some guys training. Once again, showing you it's always physical training with distraction throughout diving. And the distractions usually. All right. So marine mammals, and we often get asked, like, how can these other animals, these other, similar creatures to us do it? So there are some very important differences between marine mammals and us. So a marine mammal, most of them can exhale around 90% of their lungs. Why is that important? One of the limiting factors to freediving in humans is the ability for the lungs to completely collapse without maintaining injury. Unfortunately, that's limiting for us. It's not limiting for them. We are also, most of marine mammals are tube-shaped. They are very hydrodynamic. They have fins and a muscular means of propulsion, which we don't. So we are not hydrodynamic in the water, and we are inefficient at propelling. So we create high lactic acid, unlike them. So we consume oxygen much quickly. We do not have a rete mirabilia. Sorry if I mispronounced that. I am from the South. So we are more susceptible to pressures and prolonged depth. Anyone who's been like snorkeling, scuba diving, even diving in a deep end, knows you get pain in your ears and pressure because of the gas-filled spaces. Our cousins in the marine mammal environment lack that. So they don't have to worry about that, or they have other adaptations. And another thing is they have a higher percentage of myoglobin in specific muscles to hold oxygen and oxygenate those areas without complete distribution, and more hemoglobin to hold it in the blood compared to us. All right. Oh, this is a picture of my cat. He likes to walk. That's him. That's Fred. All right. So spleen and diving, somewhat of a controversy of how much does the spleen sequestration and release in free diving and scuba diving matter. You can see the stats up here. I'm not going to go through them in depth, but you can see there are some discussions about it. What I can tell you for me is every time I dive in my upper left quadrant, I get this kind of strange tickling, almost like climbing a rope just here every time. So Exactly what my spleen's doing, I'm not sure, but it's obviously something with the spleens going on. So I believe it. How much of it actually matters, how much of it's genetic, how good these studies are, I can't tell you. But it's something we talk about in diving. And if you look at some of the textbooks, some of them go into it really in length. Others say it's a controversy requiring more working up. But once again, anecdotally, I notice pain or like a sensation in my upper left quadrant every time. So I think something's going on. All right. So pathophysiology of diving. So it's this first word, niggles. And when I got to the diving command, they started talking to us about niggles. And I was like, this is not a word. This is not a thing. This sensation is actually why the Navy spends hundreds of thousands of dollars training us to go through diving. So anyone here or anyone listening who's done scuba diving knows that immersion in the water always leads to like an odd feeling, an odd sensation. And the ability to recognize normal versus abnormal is essential. Unlike every other medical condition, other than maybe some high altitude flight or astronauts, we can all experience it because most of it occurs at roughly 1 atmosphere. Diving is different, okay? So almost every diver, if they came up and talked to you, would seem pathological. I'm tired, I'm dehydrated, I noticed my heart was beating funny, I was weak, I was confused. All that's normal at depth, right? So that is the real reason why we dive as physicians, is to be able to recognize these disease states. And the things that happen are extreme bradycardia. It's very common to have heart rates down into the 20s. When you're down there in the still of the ocean, especially as a physician, will be like, you'll notice this profound contraction of your heart. And it really is like every 20, 25 beats per minute. And you're just down there. You get arrhythmias, usually they're PACs. Sometimes you'll get some bigeminy, but these arrhythmias definitely occur. All our divers are cold. I talked about dehydration. We'll talk about bubbles later. And then another topic, which I bring up because we're a coastal town, is swimming-induced pulmonary edema. Not really a dive injury, but very pronounced. So under the same effects of immersion, shunting blood centrally, we can see in high-performance athletes doing strenuous exercise, they actually get like an alveolar rupture. They get a pronounced and almost catastrophic presentation of bright red, frothy blood from the mouth, a sense of panic. And the treatment is oxygen by mask and Lasix and not intubating. It goes away in about 10, 15 minutes. The first time I saw this as a diving medical officer, I was sure the guy was about to perish. And one of my buddies who was more familiar with it was like, we just wait. And it goes away. And why did I bring this up? You may see this, like some surfer or someone on the beach may come up with this because we have cold water, big waves, high exertion, high performance athletes. So very pronounced if you see it. And just part of that physiology that's different, right? Because we're not used to central shunting and high performance athletes or young, healthy men otherwise, and they get these weird presentations. Something I didn't put on the slide, but another thing we deal with is almost all of our athletes are patients are 20 to 30 and otherwise healthy, but we have to worry about other things, right? Alcohol, supplements, tobacco, and caffeine, all of which can predispose you to more diving injuries, which we'll talk about. All right, so bubbles. Anyone who's loosely familiar with diving or scuba diving is familiar with the BINS or DCS, which is a disease of bubbles in the tissue. Bubbles in and of itself, you would think, is a super simple topic. Bubbles form, they cause an ischemic event, we crush the bubbles hyperbaric. Unfortunately, it's not that easy and it's not that simple. If you talk to the hyperbaric trained academic DMOs, they are very peculiar about how you phrase bubbles, and we don't really know what it does. In the words of John the Miss, if a lot's written about it, a little is known about it. And there is a lot of text on what happens with bubbles and bubbles pathology. These are some of the main topics, which you can see mimics a lot of other pathophysiology of the vascular system. For me, as a operational medical officer, diving medical officer, bubbles are a problem. We're going to crush them in the chamber, and I'm going to move on. So most of us don't think that academically about it. but if you look it up on your own, just be prepared. There's a lot written. All right, so what are our neurological concerns? Decompression illness, our second bullet, bubbles in the blood or the bends. Two types, which I'll elaborate, and then the arterial gas embolism, which is rupture of the alveoli, bubbles entering left-sided circulation and causing acute ischemic event. So we have this graph here. The one on the right is showing AGE that's supposed to represent the alveoli rupturing and then air getting into the vascular system. This more complex document or diagram on the left is basically showing bubbles forming in the various tissues and causing problems. Not the greatest graphic, but what I want to really emphasize is the AGE is a direct insult to the lung and the alveoli. DCS is this vague, widespread off-gassing of bubbles in various tissues with presentation specific to those tissues, and it may not present as much as a stroke. All right, so this is showing an AGE, so we can see the alveolus on the bottom of the diver is normal size. As we move up, let's see if I can get this. All right, it's not gonna work. All right, so here we show distension of the alveolus and then rupture of the alveolus. These are showing air bubbles entering right-sided circulation and then causing ischemic event secondary to occlusion. These generally present within 10 minutes. The ones I have seen have been diver reaches the surface, diver's unconscious. Very easy, catastrophic. 1 minute they're up, 1 minute they're not. Sometimes they'll talk to you for a brief second, a couple sentences like, I don't feel good, or what happened, and then lights out. And we'll talk about more in the hyperbaric chamber. Once you get them to depth, they wake up. It is remarkable. DCS, decompression sickness, decompression illness. There's some debate about which term to use. I use both of them. I don't think there's anything wrong, and I actually just use them arbitrarily depending on how I feel. So you can see there's a time lag on when these symptoms present, and there's several arguments for that. Is it an increase in off-gassing during those times that causes an increase in severity, or is it the act of denial within the diver? I can't be bent. I can't have this. I'm just tired. And it's hard to say. It's probably a little bit of both. As someone who dives extensively, like I said earlier, you always feel off when you get up out of a long dive. You're cold, you're dehydrated, you're hungry, and the pressure itself makes you feel generally bad, especially if we're doing air dives, as opposed to nitrox, heliox, or one of these other higher percentage oxygen dives, which actually make you feel better. Air dives wear you out. All right, two types of DCS. Type 1, generally not a huge concern. In the Navy, we would still treat it. If I was a civilian doctor, I'd probably give you oxygen and just watch it. If I didn't have access to a hyperbaric chamber, I wouldn't be too concerned. So that's going to be a single joint, non-trunk. You may have some itching of the skin, or you may just be a little tired. Type 2, which is on the next slide, that is a medical emergency. And that one, we're going to get you to death within 10 minutes of presenting of symptoms in the Navy. And that type 2 is the one that can have permanent sequelae. All diving injuries get better with time in the same way that all bleeding eventually stops. Okay, so we usually want to intervene and not let it run its natural course. All right, so this is DCS, DCI. You can see there are a large amount of presentation, signs and symptoms that can be very confusing to other illnesses, other injuries. Our DMTs and our Navy divers are all qualified to run the hyperbaric chamber without a diving medical officer. The purpose of the diving medical officer here is to make sure that these symptoms are not secondary to a secondary pathology that requires another form of medical intervention. And we actually work as a team. There's usually 6 of us involved in treating a diving casualty. And it's an open discussion as we figure out what it is, why it is, and ruling out other things. In my experience, the ones that would concern me the most is actually vertigo. So inner ear DCS is an extreme emergency that can result in permanent and intractable nausea and vomiting and vertigo. It's usually irreversible injury to the nerve. Luckily, it usually only affects one side, but any diver who has this inner ear vertigo or inner ear DCS will never dive again because we see these injuries. The rest of them, even though they may be more dramatic in presentation, generally resolve without incident. Okay, so how do we use hyperbaric treatment? Currently, our most common treatment is this treatment table 6. If we look here, we see it's 4 hours and 45 minutes of treatment at a minimum. Usually it runs greater than 6 hours as we do extensions. So here on the y-axis is our depth in feet of seawater, and here is our time in minutes. So we immediately get our diver to 60 feet as fast as we can, generally a foot per minute. We get them in what's called a bibs, which is basically looks like a bag mask, a special type of breathing apparatus, and they start on their oxygen treatments. Every 20 minutes, they take the mask off and have an air break to prevent O2 seizures. During this time, every period, we will actually try to elevate the dive medical technician out and put a new one in so that the dive tender or the medical officer doesn't get bent as well, because they are also at risk. And the diving medical officer at depth or diving medical technician cannot wear the oxygen mask because if they seize, no one can help them. So we're actually exposing ourselves to injury during these treatment cycles. So we try to come in and out as much as we can. And there are definitely case reports of the medical officer suffering diving casualty or diving injuries during this time. All right. After 3 cycles, we'll ascend to 30 feet. And this is really our decompression stop to prevent from causing another diving injury to the diver. All right, this is the gold standard. The Royal Navy also has a very similar table. I think they call it like RN62. We had ours first. I'll let you guys decide who's better. And we do this for a couple reasons. One, the pressure crushes the bubbles, okay? The exact mechanism, once again, not really known, but the idea is it reduces bubble burden, allows for increased blood flow, increased oxygen flow. They breathe oxygen to, one, increase their SpO2 or PaO2, as well as wash out that nitrogen gas in the same way that we would pre-oxygenate a patient. So you can think of this as an extended pre-oxygenation at pressure. That's all we're doing. And just like in the OR, we have the patient lay flat, and that's pretty much it. So they're just laying there for 4.5 hours flat. And so space is at a premium. I talked about size. This is what a standard Navy dive chamber looks like. And if I can emphasize one thing from this talk, if you talk about it, recompression chamber, not decompression chamber, because a decompression chamber would lead to very bad outcomes. A recompression chamber leads to very good outcomes. And very common for everyone, even new diving medical officers, to call it a decompression chamber more than once. So how does this work? We have a large steel door here to seal to allow us to dive down. We have a single cot for the casualty. The steel door in the back is what we call an elevator. Medical supplies, waste can go up and down through that. It's another chamber. We have various oxygen rigs and oxygen lines here. We have portholes so people can see what's going in, and that's pretty much it. And this is what it looks like with 2 divers inside of it. So you can see it's an extremely tight space. You're down here for at least 5 hours. And this is one of the larger chambers that we have. So these are permanent structures built into either the deck of a ship or into the foundation of a hard facility such as Naval Diving Salvage Training Center. For our operational realms in the expeditionary fleet, we actually use a much smaller TRCS model. Less gas footprint, it's lighter, we can move it around, but that comes at the cost of space. So much, much, much tighter, much, much more uncomfortable. And this one you can see does not have an elevator. So when these guys go in, they're in there for the whole time together. And so you make sure you're good friends. All right, so I talked earlier that we do everything the same, and I apologize for this form not presenting very well. In the Navy Dive Manual, which is available online if you want it, there's the Appendix 5 Alpha neurological examination. And what this is basically showing, is how to describe all the questions to ask so that any DMO in the fleet or DMT in the fleet or dive IDC, we all do it the same and we can all communicate. And the idea for this is we may not have great communications between us, right? We may have limited radio comms. We may have single transmission once a day, and we have to make sure everything's fine because communication in the battle space or through an international realm is extremely difficult. And we may have only one time to relay this. When we do record it, it's going to be in this format. All right, name, history. The history for us is what dive rig were they doing? What tables were they diving? What gas were they breathing? Anything else special about this dive that helps us delineate? What was their mental status when they reached the diving command or diving medicine? A very simple coordination, strength, cranial nerves, reflexes. And then this schematic is to show where they're reporting dive symptoms as I talked about earlier, right? Joint pain, ear pain, dizziness, and then any comments, and that's it. And you move on. From the time a diver reports to a diving injury, this form needs to be done in 10 minutes. And if a diver is stricken or has a dive injury, they have to be at depth. So that's our time window, 10 minutes. And I have never seen it not executed in 10 minutes. All right. So, sorry about that. So nitrogen narcosis or rupture of the D is a fascinating subject in diving if you're an anesthesiologist. So in the Myerton-Overton curve, nitrogen is actually at the top, and at significant depth, starting at about 70 feet, it starts to act as an anesthetic. And we can see through here how it increases at depth. The presentation of nitrogen narcosis is an immediate symptom at depth. So it doesn't generally increase with increased duration at depth, and it resolves with coming up just a few feet. You can ameliorate this by diving different gases, such as argon or helium. And when you hear about technical diving or deep diving, this is what usually limits us, or this is what causes catastrophic outcomes. And you may have heard of technical divers or deep water divers switching on the wrong tank. Well, what happens? They get narcotized and they get confused. We have case studies in the Navy of guys at this 250 to 300 realm taking the regulator out of their mouth because they think the fish near them needs to breathe and them drowning. So it is an extreme hallucination, extreme narcosis. We take all our divers down to 165 feet in the chamber to narcotize them for 10 minutes. And we actually film them because most of them don't remember, and we show them what happened so they have a profound appreciation for this. And it's amazing because you'll watch them. So half the class will watch and the other half will go down and we switch. And you'll see your buddies just acting silly, for lack of a better word, and they don't remember it when they come up. And they are fully, what you'd say, fully coherent, right? They're talking, they're chatting, they're not slurring their words. They're just acting a little giddy, blackout. So now imagine that at depth. And even at 70 to 100 feet, you may feel some euphoria or other things that are distracting, a loss of time. And all these things can lead to more diving casualties. All right, here's the picture, more distraction, more dive training. All right, so diving injuries, what do we see most of? Barotraumas, which I have a slide, infectious and environmental diseases, and then trauma. So let's talk about trauma. So you'll see here, this is me. Oop. This is a hydraulic chainsaw for underwater work. So we have ship husbandry and engineering divers who have an entire plethora of hydraulic power tools for clearing waterways, building piers. And as you can imagine, injuries happen. All of it's a novel situation, and Navy diving is very safe, but it's something we just have to be prepared about. All right, so what about barotrauma divers? As a diving medical officer, this is our bread and butter, our most common area. What are the vulnerable areas? Gas-filled spaces, sinuses, ears, and eyeballs. So I understand eyeballs don't have gas, but the mask does. So we see injuries to the eye from the gas-filled space in the mask. Most of these are just a minor nuisance. However, they can be catastrophic. And they can occur either on a descent or ascent. So how do things happen coming up that if they were able to get down? Divers have taken Afrin, Sudafed, and then these medications wear off. They have a slight injury at depth, and that leads to inflammation of a sinus tract or the eustachian tube. And then as they rise, they're unable to offset the expanding gas. It can be as catastrophic as ethmoidal sinus fracture, maxillary sinus fracture, rupture of the TM. So we will see these things. And when I say they're missed by non-specialty trained physicians, most ear pain and sinus pain is going to be associated to sinus infection, things like that. These generally all get better with just time and understanding and education. All right. Now, where they become a problem is if you have had an injury of ascent or descent and you're unable to clear, and now you are a stricken diver, and I have to get you back down to depth because I can't injure you more driving you down in the hyperbaric chamber. And these become very novel situations about how do we do a myringotomy? How do we get this guy down? Is this diver unconscious? Is he able to clear? What injury are we going to do? Getting him to depth and keeping him at depth if he can't equalize on his own. All right, rescue in the marine environment. So when I showed you earlier, lots of physical intense training, all of that really denotes down to the ability to self-rescue and buddy rescue and not being a liability in the ocean. So unlike many other environments, mountain, land, once you're in the ocean, you're at the whim of the ocean. So we train and train and train. The first thing we do is make sure you're safe, you're physically fit, you know your protocols, and you're able to take care of yourself. We always dive with a buddy diver, and I'll show you some videos before this that show how we work to protect each other, always keeping our eye on each other, because sometimes it's not a physical deficit, it's nitrogen narcosis, it's hypothermia. Has this diver suffered another injury that's a neurological compromise and he's unable to think on his own? Because at depth, you know, the team's not there. Usually it's just two of us. If that doesn't work and I'm unable to help my buddy, how do we work as a unit? Or nightmare scenarios, nighttime, bad weather, dangerous marine wildlife. You know, are we in enemy or hostile waters? How do we get people out? And these are things we do. We review in what we call an operational risk management or ORM before every dive. So we will write out every possible potential complication that could happen and how we're going to fix it. And so we're all on the same page. This is just showing some guys who are going through a similar idea of rescue. So you can see they're all in boots and camis. They'll be getting into the 40-foot pool and training basically the point of failure so they know what it's like to be exhausted in the water to the point where they give up to understand how to be rescued. All right, here's what it looks like rescuing a buddy diver at depth. This is how it's supposed to look. Nice, smooth, clean ascent. This is how it usually looks. It's never as nice as you want. There's currents, people are moving, you get turned up in your lines. And so we train a lot to do this. As DMOs, we are not quote unquote rescue swimmers or rescue divers, but all divers are trained to perform self-rescue and buddy rescue. Baby. All right, here's another video showing about how we work as a buddy system. So as they're moving to the objective, which is this little orange buoy right here, one diver is watching where they're going and the other one's looking back at him. And they're trying to maintain hand distance from each other at the entire time. So if something goes wrong, they can reach and hold on to each other. And the reason for that is we are usually in murky water like this, where visibility is 1 to 2 inches at best, sometimes a little more. So you have to have that tactile sensation in the dark.
5 minutes.
All right. So infectious and environmental diseases. Unfortunately, most of the waters of the world are not clean chlorinated pools, but cesspools of filth. And we dive in all of them. And a lot of our diving is in busy ports with infectious material, chemical material, hazards. So we see infections in our diver, with otitis externa being the most common. In the civilian world, otitis externa, 2 weeks of antibiotics, no water. We give you antibiotic drops and you go back in the water the same day. Now, the difference is you are seen by a diving medical officer every day to make sure you're not having any tympanic injury or worsening of it. But we dive these guys without problem every time. Fungal otitis externa is much higher in the divers. The fungal otitis externa, while easy to treat, is a much greater concern to us because we do see tympanic membrane rupture in the divers who get this. So we will not dive them until it's cleared, and we watch them much closer. In my experience, I've seen 2 divers get fungal otitis externa, which either misdiagnosed by a non-diving medical officer or they didn't report it, and they did get tympanic membrane rupture and were out of training. COVID. So I was part of the quote unquote plague class that was a dive candidate during COVID, and we had to mitigate COVID risk. And as with everyone in the medical sector, we progressed throughout and modified. But basically at the end, we decided that there wasn't a lot we could do. So we just quarantined everyone, isolated them, and diving went on as normal. And the real reason for this was most of our divers are 20 to 22. They live in the barracks. And we knew as soon as they got home, they're going to play video games together, sit next to each other, share beverages, and the disease was going to run its natural course regardless of our best efforts. And we lost 0 classes during COVID. So by isolating ourselves kind of from the community and having a very rigorous screening protocol and amnesty policy. So if anyone thought they had any symptoms or exposure, they called in, they didn't come into work, and we were able to proceed with relatively normal operations. Red tide, especially in Florida, can be a huge deal for diving. We are unable to shut down diving in the entire Gulf of Mexico because of the red tide. So how do we mitigate that? And each red tide presents a little differently. And this is something I would work with the line or the skipper, the diving side as opposed to the medical side, and how do we identify hazardous areas? What are our decon procedures? What dives have to go on? And how do we train people? And a lot of the injury of red tide or the concern for it does not come to the divers itself, but the crew from the aerosolized effects of the red tide. So upper airway irritation. So actually the divers are pretty safe because we can put them in like basically a decon suit. But it's the dive tenders on the ship are actually the ones who get affected and have problems, and they're unable to safely manage the divers themselves. All right, so I have it at the S slide. I didn't write these last slides. The Thailand cave rescue is an issue. So we're actually in phase 3. Sorry, that slide must have dropped off. So one of my buddies was actually one of the parajump rescue guys who participated in this, and he went ahead and wrote these slides for us. So we can all remember in 2018 when this happened, right? A group of soccer players went into a cave, rain happened, and they were trapped. And a international response of us, the Brits, the Chinese, the Australians, all responded to help, as well as the Thai Navy SEALs. This is the soccer team here. So what is it important to us from an anesthesia perspective? This Australian anesthesiologist here, Dr. Richard Harris, actually came up with a plan on how do we sedate these kids to safely get them out, because we can't have these kids swim on their own. And from a diving standpoint, this was an extremely technical and complex dive. And hats off to this guy for coming up with this plan. The medications we did here, as you can see, the children were then secured in the prone position to the divers, and then they swam out with various waypoints, as you can see here, starting at 9 and then moving to the exit. And talking to the guys who did this, they said they were in total dark. They couldn't see the kids. They couldn't determine if the kids were breathing. So they were just traveling in terror, hoping the kids were still alive as they proceeded through this multi-hour dive. The U.S. forces were not involved in the personal care of the kids for some political reasons beyond my pay grade, but we were there as expert consultants. All right. All right. And all the children made it out safely. One Thai diver did perish in this, if you remember, but that was due to an unrelated thing where he got lost without a child with him. All right. So another item that I think is super important is women in diving medicine. Are there women in diving medicine? Absolutely. Well, why were there no pictures of women in diving medicine? Well, by chance, I went to the only diving class in the last 5 years that had no women. So that was it. Usually there's 2 to 4 out of a group of like 12 to 16. I said 2 to 3 here, but it's usually more than that. Why are there a little less than men? Well, unlike the civilian match, in the Navy match, we list 2 specialties. Once you match, you actually pick what you get after you match. For whatever reason, it seems like we just lose a little bit more women, even though the match is generally equal, male and female, to the diving medical officer classes. I don't have those exact numbers. That's just what I've noticed. The women we get are all extremely tough, extremely athletic, and they have this, there's one standard, gender neutral standard. So there's no, the women have it easier. They have it just as hard. In fact, I would say sometimes they have it harder because that's 200 pounds. My 80-pound dive gear is less than half my body. I don't know the weight of women, and I'm not going to say I think it's classified, but it's obviously much less and a much greater proportion of their body weight. So, and it can be very impressive because these tanks, unfortunately, I don't have a video of it, but the swimming and testing in full dive gear is arduous, even for me. And out of all the events I've done, high school, college, like not professional, but recreationally, and then diving, the in-water training with your dive gear was the hardest thing I've ever done, cardiovascularly. And so hats off to these ladies who do it, who weigh half as much as me. The training or the requirement you have to do to become a DMO, 500-meter swim, and we're doing this in those little shorts and a t-shirt and wet shoes, 500-meter swim in under 2:30. Important to emphasize, there's no lanes in the pool. You don't have goggles on, and you just go. And there's like 14 people in the pool. You get a rest, max push-ups, 2-minute rest, max sit-ups, 2-minute rest, max pull-up, 2 minutes rest, and then a run in all your wet gear, and that's it. And then they do it. Everyone does it. So you have to do this before you get there. And then before any training starts, you do this test again. And then when you go to dive school, you do this test again. And then to graduate dive school, you do this test again. So you can't just like fudge it. You know it's coming. It's never fun. And that's women in diving medicine. Like I said, I apologize. I don't have any pictures. Oh, this slide. Here's a picture of the rescue. And I think here are my resources. And special thanks, Dr. Parsons, for helping me put this together. HM1 Bobby Whitted, HMC Laddie Aldridge, Senior Master Sergeant Ken O'Brien from the Air Force, who put together the the Thai rescue slides for me. And then the Marine Mammal Center for sending me those pictures of seals in the beginning. These are my 2 cats, Bambi and Fred. Fred thinks he's a dinosaur. And then any questions?
I have a mic. I have actually 2 mics. If we have time for maybe 2 questions. And while you're thinking of questions, there's a question online about your favorite place. Oh, favorite place to recreationally dive.
Easy, Miyakojima, Japan. So Miyakojima is a southern island in the Ryukyus chain, which is where Okinawa is. While Okinawa is beautiful, it's still a little developed. If you go to Miyakojima, untapped natural beauty, beautiful reefs. I would give you a warning to read the signs before you enter the water. I was down there diving with my buddies. We were like, this is great. No one's at this beach. We went out. We had like an hour-long dive. We came back. And for whatever reason, the signs were facing the ocean, not facing into the ocean. And in very clear language, it said danger, tiger sharks. So just be aware of what you're getting into, but nonetheless, it's beautiful. So Miyakojima would be where I'd dive anytime.
So this relates to air entry from the alveolus into the pulmonary circulation. We're all kind of taught that, if you say take a deep breath at depth and ascend with a closed glottis, that's a setup in kind of a panic situation. Are there any kind of more innocuous, benign, everyday situations that lead to that?
Yeah,
problem?
so blebs, right? Pre-existing blebs can actually do that. You can have a incidental or spontaneous pneumothorax or injury that could lead to an alveolus injury, but most of them are not spontaneous. Now, things that can be more insidious, it can occur in like freshwater or altitude diving, where because of the change in density, you actually have to ascend slower than you would in our saltwater. and we will see it there where people are like, I ascended at my normal rate and I had an AGE. That will happen. Changes in breathing, divers who are not fit, right, who are exerting more may be more predisposed to it. But other than that, and then when we train, we're actually taught to just come up immediately. And what we do is we actually scream as we come up, in the same way as the sub rescue, which was not part of this. If you escape a sub and you use this flotation device, you just scream the whole time to empty your lungs. But yeah, other than that, not too much that I have seen or that I've read about. Usually it's very predictable, unlike DCS. Sir.
Motion sickness,
Oh.
seasickness, and even underwater getting vertigo underwater. I would think that would be very common.
Seasickness is extremely common. So what are the risk factors for seasickness in diving? So the normal things exist, right? A prior history, rough ocean state. But what will happen a lot is, and we don't think about this as people who spend most of our time on the surface, is currents exist in different directions at depth. And you may lose your natural horizon at depth, either due to visibility or just the motion of the ocean. But what really predisposes people is either being a horizontal plane or focus on a specific object, a task, a fish, and then they start moving sideways slowly and they don't realize it. And then you kind of have this catastrophic motion sickness. We use the Conshell 14 regulator in the United States Navy, which is actually has these designs called whiskers so that we can vomit through it and it doesn't chunk up. And speaking from experience, it works really well. So the thought of having MSS underwater seems terrifying. Anyone who's been sick and vomited, it's always a bad experience, and being underwater doesn't change that. Like, you're not breathing anyways, right? You're retching and you just kind of go through it and then you put yourself back together. And in fact, in a lot of ways, it's much nicer throwing up underwater because you're clean and you just kind of push it away. That being said, the thought of it is terrifying, but when it actually happens, it's not that bad. Other things that predispose, your wetsuit's too tight, you get hot. So all the other things, right? Tight, restrictive clothing, movement, dehydration, all those will do it. I know when I'm going to get seasick at every dive, it's like I said, I'll take a drop and I'll kind of get this horizontal push while I'm focused and I'll be like, ugh, I don't feel good. But once seasickness starts, whether at depth or on the surface, the only cure is really to get back on shore. And then another thing we see is land sickness. So seasickness that presents once you're on a stable ground. And we'll see this, what is it, mal de embarkment? There's a pretty French term that I'm sorry I've forgotten. So it's almost the same thing, is you will adapt to the motion of the boat, you'll get on land, and then you'll start feeling seasick. And it can be very pronounced. The treatment, that's usually triggered by fatigue and dehydration. And the treatment for that is just rehydrating and going to bed. And most 99% of the time they wake up and feel fine. So we may give them some Benadryl just to help them sleep, but it's usually self-limiting. But it does feel bad. And I, unfortunately, am very predisposed to that. So I'll do great on the boat and I'll get off the boat and I'll have to excuse myself and then go to sleep. Any other questions? All right, real quick, here's my contact information. If you have any questions, don't hesitate to text, call. I'm moving to Japan in September, so this number will no longer work. That's my email. The best way to reach me is my Instagram. If you do reach me from there, please say you got it from this chat or this talk, so I don't think you're just like a spam. And understand I work for the military, so if I'm gone and I don't respond, just text again. If you leave your phone for 2 weeks to 4 weeks, you come back to a lot of text messages and emails, and it's easy to miss. I'm not blowing you up. I want to talk to you, so just reach out again.
All right. Thank you, Dr. Sanders. This was fantastic.